I think a lot of us immediately would look at that dog and say, ugh, like this is a true emergency. You see it's kind of stretching its neck out. The owners say it's been trying to vomit. The stomach looks a little big. What would be your first thought that you're going to do?
Hey, VetFolio Voice listeners, welcome back. So glad you tuned in. This episode features one of my favorite people to podcast with, Dr. Tannetje Crocker. You can also find this one cross-posted on her platform, Questions with Crocker, so lots of opportunities to listen. Dr. Crocker is insightful. She's so fun to talk to. She's great at putting into words the thoughts that I feel like I sometimes struggle to express, and then she will repeat them back to me, and I'm like, oh yeah, now it makes sense. And in this episode, we're talking about ER essentials for the general practitioner. We tried to approach it in a case-based way, breaking down real case scenarios to help make these concepts as applicable as possible if they were to walk through the door in general practice. This conversation was really timely for me because, as you'll hear in this episode and some of the upcoming episodes, I've recently made my own career transition and I've closed my house call practice, which was a tough decision, and I've moved a little bit more into the emergency and urgent care space. I've been lucky enough to work with an amazing clinic full of resources and support, so it's been an incredible learning experience, and this conversation just felt really timely. Really, I feel like it's been interesting seeing things from both sides. I, for so long, have been the one referring cases. Now I'm the one receiving them. And Dr. Crocker brings that same kind of dual perspective. She came from the equine world and has been in emergency for quite a while, but she also owns a general practice. And we both tried to bring that well-rounded view to the discussion, what primary practices can handle, when it makes sense to refer, and what that referral partnership might look like. Like I said, I really enjoyed it. I always enjoy talking with Dr. Crocker. I hope you enjoy the episode too. If you don't already know who she is, let me tell you a little bit more and we'll get into our episode. Dr. Tannetje Crocker is a 2009 graduate from the Texas A&M University College of Veterinary Medicine. She's passionate about mentorship and empowering both veterinary students and young veterinarians to embrace the profession and find joy and success. Growing up, Dr. Crocker was always passionate about horses and was inspired to become a veterinarian. Since graduation, she's worked as an equine ambulatory vet, small animal general practitioner, and as an emergency veterinarian. She currently lives in Texas with her spirited 9-year-old daughter, funny 5-year-old son, and supportive husband of 15 years. Let's go ahead and get into our episode.
Nutrition is the cornerstone of our patients' health and happiness. The veterinary healthcare team should be the ultimate source for top-notch pet nutrition info. When clients see how the right diet helps their pets stay healthy and happy, they visit us more often. Remember, good nutrition is essential. It's smart business and great medicine. Enroll in the NAVC Pet Nutrition Coach certification today on vetfolio.com.
Well, welcome everybody. I was so excited this morning to look at my calendar and see this episode that we were putting together today. I'm joined by Dr. Tannetje Crocker. We've recorded together before and it's always so much fun. So thank you for joining me. I'm excited to get into this.
Thank you for having me. I am excited that we're going to put this out on, obviously, VetFolio has great information, but I get to put it in Questions with Crocker too, which has a little bit of a cross audience with pet owners and veterinary professionals. So that'll be good info, I think, all around, and hopefully somebody will learn something.
Yeah, absolutely. Well, I know that this is a talk that you give in different contexts. And so let me just toss it over to you to begin with. Where do we start when we're talking about ER essentials for general practitioners?
So I always like to get into the why of something and not just jumping in. And I like to just lay the groundwork that I think we're talking more about this because we're seeing more same-day urgent care appointments in, regular general practice. During COVID and after it, everyone was pretty overwhelmed. There was a lot more people being pushed to urgent cares and ER specialty centers. But, some of the visits have dropped off a little bit, the preventative ones, and things have evened out. And so a lot of your general practitioners are seeing more of these pets in-house during the day. And I think that, it's important to just kind of think about the basics and the things that we could be doing, and maybe a little bit of newer information that's come out about some of these more common emergencies emergencies. So I decided to start giving this talk, and it's always fun. I mean, you know this, it's fun when people show up, but it's also fun when you give a talk and afterwards, people say, oh, this was actually great. It was a good refresher. I learned some new things. And so every time I give it, I feel like the interaction is good and we have good conversation. So hopefully it'll help a couple other people. And along the way, I always, learn something too. So
yes. Yeah. No, I love all of that. Kind of like you have a foot in both camps here, where I'm kind of newly transitioning into the emergency world. And, like you said, in general practice, we are seeing appointments even out a little bit more compared to when we're dealing with the COVID level of busyness, let's call it. In the ER, I don't know what you're seeing. We're pretty busy still in the ER. So
yeah. I work mainly nights. And so I'm definitely busy because I'm the only option, at night, but I own a general practice and we actually keep same day appointments available, and we have a fair amount of urgent care. And I think some of that does speak to also the cost. There is a difference going to your general practice versus urgent care. And I think a lot of general practitioners want to make it accessible for owners that are having, an emergency. If they can help, they want to.
Absolutely. Absolutely. And sometimes, you're just the closest person to that emergency in general practice. We had one not too long ago. I was working at the GP hospital where I work, and the owner called and it sounded like a potential status epilepticus case. And the closest ER was 20, 30 minutes. It wasn't terribly far, but for a status case, that can really be a big deal. And so sometimes you're just the closest person and they need immediate attention.
Yeah. And I think we're going to get into a little bit of some of the things that maybe if something does come in the door and you know that it needs more care or longer care than you can offer, but still there's some things that you can do as a general practitioner to stabilize and to really set the pet and the owner up for success if you are referring them to, a 24-hour facility. So I think also thinking about some of those things and getting better outcomes in some of these cases is great knowledge.
So let's give some examples. So what are 3 common emergencies that you see present? And when you see these emergencies, what are some of the aspects where you really appreciate it when the primary veterinarian starts the workup or starts treatment or something like that, versus are there things that you see come through the door where sometimes you're like, oh, I wish they would have left this to us. It might have been a little simpler.
The most common emergency that we see is vomiting, diarrhea, but we're going to talk about like the true emergencies today, the things that, most of the time do need immediate stabilization or need something really emergently, whether they're in the GP or the ER. So one of the most common ones that I get referred because they really do need more usually or hospitalization is GDVs or hemoabdomens. That's one of the most frequent ones. And we see those dogs come into the ER all the time. So for people that aren't familiar, GDV is going to be gastric dilation volvulus. So when the stomach swells up and then it flips and basically cuts off circulation to everything that's important. It is a true emergency because the longer that stomach is flipped, the longer you're not getting circulation to the stomach itself or to the spleen. You can get pretty significant necrosis, and you also can get toxin release, and these dogs can absolutely die. And it's interesting because sometimes people will just feel like their dog is off a little bit or their stomach looks a little bigger. They won't know how big of an emergency it is because it's usually those larger stoic dogs. So it walks into your clinic, and I think a lot of us immediately would look at that dog and say, oh, okay, we need to jump on this case. Like, this is a true emergency. So I want to ask you, like, let's say you're working, what's the first thing you're going to do with this dog when it walks in the door? You see it's kind of stretching its neck out. The owners say it's been trying to vomit. The stomach looks a little big. What would be your first thought that you're going to do?
Well, I mean, I guess, certainly it depends on how stable the dog is. If the dog walks into the clinic, then I feel like you said, this is a true emergency. This needs attention right away, but I don't have 5 minutes. I have a little bit of time to figure out what's going to happen. So, I think certainly getting a diagnosis, if I can get radiographs and send them over to the ER, maybe I can get some catheters placed and start some fluids going to start on our resuscitation journey. But then, yeah, certainly then we would get very quickly to client communication and, okay, what are we going to do about this?
No, that's perfect. So first you need a diagnosis. I mean, a quick right lateral x-ray really should be diagnostic for GDV. And I like the thought of, if you're not sure, even just taking a picture really quick with your phone and emailing it to, the local clinic and saying, is this a GDV? This is what I'm dealing with. And absolutely, for me, it's a lot of things happen at once. You take that x-ray. As soon as the team sees it, you see it, and you know it's a GDV, then ideally, yes, you're placing an IV catheter prior to sending the patient. You're giving usually a pain medication. It's a really painful situation that this dog is in. And then if you do have time, you're talking to the owner through options, you're actually going to give like a fluid bolus or two. So a 5 ml per kg bolus, because we know that these guys aren't getting great perfusion already. And so that is going to help them. And then I don't know if you've ever trocherized, but I think it makes people, a little nervous, but it's actually a pretty straightforward procedure. And even if you don't have an ultrasound, if you just go a couple of centimeters, they're laying on their right side and you go a couple of centimeters coddled to those ribs, and you can actually feel that drum of a stomach. And then, you scrub, and you can take just a regular IV catheter, the longer ones. And I usually do an 18, and these dogs are so painful. Like you can do a little lidocaine block, but a lot of times they feel horrible, and hopefully you've already given a pain injection. And so you're just going to, put that catheter in. And then one of the things I like to do is from underneath, I'll kind of pick the stomach up so that air really rises to the top. And I just let it flow. I try to get as much air out as I can. You see them get a lot more comfortable. Those gums go from kind of muddy, ugly looking to a little more pink. And that's something that can buy these dogs a fair amount of time if you can kind of get rid of some of that pressure on the stomach. And then, like you said, it's a pretty quick conversation, because this is like it's bad to say, but it's an all in or all out situation. Like the owners even need to say, I'll do surgery or I won't. So you're kind of doing some of those things and talking to the owner, and then you're either sending it or you're having to have, hard conversations. But I think those are pretty basic, straightforward things that any general practitioner can do and feel confident in.
Unless, you are a brave and talented surgeon and you're going to cut it right there yourself,
Absolutely.
Which in those cases, more power to you. I mean, it would have to, I feel like I would do it under extreme duress, but otherwise be like, no, thank you. Let me send it.
But you could. Yeah. I mean, there's general practitioners that absolutely do these surgeries. And I think that, when you do this surgery, the nice thing is just to make sure that you have really good anesthesia help, because even when you derotate the stomach, you're going to get some pretty significant hemodynamic changes. And so you can see some things happen. And then if you get in there and the stomach is necrosed, sometimes you do have to resect part of that. But I will tell you, that freaks people out. But the stomach is actually a really hardy organ. And if you can resect anything, that it's the stomach. I mean, you can take a pretty large part out and you can close it and it will heal great. And a lot of GPs do, gastrotomies and foreign body surgeries. And so I think it's kind of the initial stabilization and derotation that is overwhelming. If the stomach's compromised, you can deal with it. And then a pexy, needs to be done. And I think that might be the part that maybe worries GPs a little bit, because doing a gastropexy is hard. But I don't know. What do you think about that? What's your thoughts?
Yeah, it's a good question. And I don't know that I'm the most representative of GPs in general, because I don't love abdominal surgery. And that's actually a professional goal of mine, to like rebuild my comfort level with abdominal surgeries and start to feel a little bit more comfortable. So for me, I've done a few gastropexies. I don't like doing them because I don't know, there are parts of it, especially when you're dealing with a deep chested, like a keel chested breed or something like that, or barrel chested, where it's really deep and you're reaching in there. And I question myself constantly, like, am I in the right place? Did I cut deep enough? Are my sutures going to hold? All these things. So I don't like doing pexies. Of course, if I had gotten in there for a GDV, probably I feel like the pexy would be like the least of my worries at that point. It'd be like, let's go for it. It's okay.
You're like, we got this far. Let's just do it. Yeah.
Right. But in general, no, I would agree with you. I don't love doing pexies.
I think it's something, it's funny because I think it's one of those things that I'll do, a few in a row and then I won't see one for like 2 months. And then, yes, I go to pexy again. I'm like, okay, wait. What do I do? How do I do it? Like it's one of those things that always does make me a little nervous, and that's okay. But, if a GP is doing this surgery, it's because they are the only choice at that moment and they're just trying to save the dog. And I think There's a lot of great videos online about how to do a PECSI. There's a lot of great information out there. I usually tell people just get another set of hands, like especially if it's your first couple times. There's some tricks as you do it more and more that will help you be faster and better at it. But the first couple times, just get somebody else in there with you and it'll make your life a lot easier.
I totally agree, because you need that visualization. And that, I think, is one of the hardest things is if you feel like you're suturing blind, then everything that is challenging about a PECSI gets that much more challenging.
So much harder, so much harder. And so, make your life easier, just grab somebody else and you'll get done faster, which is better for the pet. And then a lot of times these guys, afterwards are very painful. And so lidocaine CRIs are really helpful, really thinking about monitoring. And so I have had these guys, cut at the TP and it's into the ER to be watched overnight, because we do know they can throw clots. Like there's a lot of potential complications, but it's definitely something that, to me, it's worth trying, because if you don't do anything, the dog is going to die. And so, if you're going to send it, try to just do basic stabilization, get some fluids in there, get some pain meds in there, chokerize. If you're going to cut it, I support you. And you can always call Veg. If you call us, we will answer and we will talk to you. And if you need to FaceTime through a PECSI, like we will try to help as much as we can, because we really want to make sure that the animals are getting the best care that they can get.
Absolutely. You mentioned a lidocaine CRI. I know these guys like to throw a lot of EPCs, so something to be prepared for and watch for there. And then splenectomies end up being a part of this surgery sometimes. So you mentioned hemodynamic changes, certainly like hemorrhage and blood pressure changes and things like that to be aware of. But I think if you kind of know the score going in and you feel like you're reasonably prepared, and like you said, if we don't do something, the dog's going to die, then I think there's a lot that we can do. But man, it sure is nice to have an ER close by. If you do have one with somebody who's like, no problem, I'll cut it. I have a colleague like that who, man, she loves these surgeries. And I'm like, it is all yours, my friend. You can have it.
I do too. There's a specialty hospital not too far from us, and they don't have a surgeon at night. And so every time I see them on the phone, I know they're calling to say, I have a GDB or I have a hemoabdomen. Like, can I send it? And I'm like, yeah,
send it my way.
I want it.
Oh, that's amazing. For people like me who, like I said, maybe that'll change one day, because I really would like this to not be for the rest of my career, that I really don't want to get into an abdomen. But at this current stage in my career, I'm so thankful when I have those colleagues close by who want those surgeries.
And another thing I just want to say, especially with like GDV, hemoabdomen, is, also making sure if you're going to send it, that you're talking to the owner about prognosis, and then also talking to them about cost. I mean, we know there is a big difference between a GP hospital cutting something and hospitalizing versus a 24-hour facility. And especially with a hemoabdomen, I mean, those cases can go great or they can not go great. You can save them. And then unfortunately, those dogs can pass away a couple of weeks or months later. And so it is really hard working in the ER. Sometimes, I'm sent cases and the owners are completely shocked by the prognosis or the cost of being there. And then I have to have like a hard conversation with them that really could have been saved, and they could have just saved at their regular veterinarian if they didn't really want to go all the way. And so I don't want it to say it always has to make the difference. And sometimes them talking to me might help them make the decision, right? I don't mind having the conversation, but I do think you set the emergency vets up for success, and your clients are in a better headspace if you just kind of go over those things too.
I would agree. And being on both sides at this point, one of the things I've seen that I hope I have done as a GP referring cases is leaving the conversation as far as what is going to happen, diagnostically speaking, a little bit open to say, my expectation is that they would do this. Of course, they're going to take a look and, make the recommendation that they think is best at the time. Because I haven't run into this being a problem, but I have had people come in and they're like, well, I need, an abdominal ultrasound, and then evaluating the case. I'm like, that's great. Like, we can do an abdominal ultrasound, but I think we can actually use our resources a little bit differently and get to where we're trying to go in a different way. And not that the GP who referred these cases, whether it's an abdominal ultrasound or something else, was incorrect in any way. And fortunately, I've had clients who are like, oh, okay, we can kind of change our plan. But I could see how that might present differently in a client who said, no, I need this test and you're telling me something different. And now I trust my GP. I don't trust you. I don't know you. Now what's happening, and create like kind of a hostile conversation. So even if you're just referring to a colleague in your practice to say, you know, this is kind of what I think the next steps would look like. And that, but of course, you know, they'll take a look and make the best call based on what they're seeing and what's going on with your pet.
Yeah. I mean, I've absolutely had patients that were sent and, you know, an expectation was set. And then when they come, they are more critical or they decompensate or, you know, something happens where we do have to adjust the plan. We have to pivot a little bit. And I'm with you. Most owners are like, okay, we're here. We can see what's happening. Like we understand. But there are some, and I think it's just because they're in such a heightened state, because obviously something is going on with their pet that is scary and hard. But then you say something different than the person that they've known for a long time. And it can make it difficult to kind of be a team to help that pet. And so, you know, if people don't know like what to expect if they're going to send a patient, or they don't know kind of the general cost of things, I just recommend they call. I mean, always call anyways and give us a heads up, right? But call and ask those questions and then make sure you can communicate with the owner, you know, in a very straightforward way.
Right. Absolutely. No, I think that sums it up perfectly. And also, you know, in fairness, if we do have somebody come in the door that says, no, my vet said we have to do this, like who knows what that conversation actually was.
That is very true.
I definitely had that one come back around where I'm like, nope, didn't say that. And,
And it's funny because working GP and ER, it's kind of like, I think I have a little bit more understanding of, you know, it's like a game of telephone. I'm like, what actually was said? And then what was said, you know, at the ER, it can be very, very different. And so I give people a lot of grace. I give referring veterinarians a lot of grace because I think the story is not always 100% that maybe we're told or what we see. And so hopefully people can do that for each other in general, you know, in vet med.
Yes, 100%. Okay, so we talked about GDVs. We mentioned hemoabdomens a little bit. Do you want to dive into hemoabdomens a little bit more? Or is there another emergency you want to talk about?
I think for hemoabdomens, honestly, if they are fairly stable, and I would just send them. I mean, I think if you can place a catheter, maybe while you're talking to the owner, great. Maybe give a fluid bolus. But really, if they are there, you're not often going to have blood products. So you're not going to be able to do a transfusion. And really, I wouldn't spend time doing that. I mean, you need to get to the source of the bleed and take it out. And so I would kind of set the expectation of when you get there, it's going to be a true emergency. You're going to have to make decisions really quickly. But if they're basically stable, I don't think there's much other than maybe giving venous access, and you can run lab work and send that with them. I don't think that's wrong, but I wouldn't spend an hour, 2 hours. I would say, this is what this is. You need to go, you know, and just not waste time.
Sure. In those cases where, I think that's good advice because you're right. We do have to get to the source of the bleed. I had a hemoabdomen not too long ago, and it was a slipped ligature, like all of our worst nightmares when it comes to doing spays and things like that. And I was so thankful to have such an amazing team because, you know, we got to get the blood back into the dog, and they were fully prepared and jumped on it. Dog did really well. But I don't know that I would have had that same level of preparedness if I was working GP when that dog came in, because that's just not something we're seeing nearly as often. So, you know, we're handling different things than doing these auto transfusions and stuff like that. So I guess in those cases, if we have a hemoabdomen that's not something like that, where we're going, you know, your dog has a really good chance that once we fix the bleed and reperfuse, they're going to do great. You know, if we are talking our classic like splenic bleed or something like that, what helps you in the ER as far as talking about prognosis? Because it is so variable with those splenic bleeds.
I would say I want to edit one thing. You could potentially take a chest x-ray before you send them.
Okay.
So because we know that these are, you know, it can be aggressive cancers. I have sometimes had people that are like, let's go, let's do surgery. I'm on board. And I say, okay, I just want to take an x-ray of the chest. Make sure we haven't already had metastasis, or make sure we don't have hemangiosarcoma of the heart. And there's, you know, check for pericardial effusion. Like there's little things. Look at the liver. Do I see any big nodules in there? Do I know it's spread already? So you could, if you're comfortable imaging wise, you could check a couple of those things. And if the dog is stable at the GP, because I do think those things weigh into how much I'm going to encourage an owner to go for surgery or not. I always tell owners that this is unfortunately one of those where I'm basically going to try and we're going to shoot, our shot and we're going to go for it. But I am just trying to stabilize their dog. And the long-term prognosis is still pretty guarded. And that the horrible thing is I can't tell them what the long-term prognosis is without actually doing surgery. And so it is one of those conversations where I'm very straightforward. And I basically say, your dog will die if we don't do this. But the difficult thing is I can't tell you that this isn't something that's already spread and has gone elsewhere. So age of pet is not a big consideration for me. I had a 12-year-old Basset Hound and that dog is still alive 3 years later. So there are some dogs that I'm like, age is not the reason. I think finances are a concern. I think just some people, telling them we're going to do this, but unfortunately it may be something that 3 months down the road, your pet is going to have blood in the belly again, or it would have spread. Some people just say, I can't do that. Like I can't just wait, and I can't just take the chance. So I think those are the big factors that determine it. But the pet status, there's not much in a well-equipped ER specialty center that we can't handle. Like they're anemic, great, I can handle that. Like they're throwing VPCs, I can handle that. So I don't think there's much that would tell me I'm not going to do it other than it has spread and there's obvious metastasis.
Sure. So I like that answer. That's actually really helpful to say, maybe shoot that chest x-ray, which might help make the decision one way or another. What you said sounds pretty much verbatim to the conversation that I have with owners of like, I wish I could tell you, what's going to happen here. But unfortunately, we just don't know unless we do the surgery. So we got to decide. And I don't know. More recently, I feel like I'm coming to this realization that you can't really talk somebody into euthanasia. So if they do say, I can't do that, whether it's finances or the emotional component of like, I just can't like wait and for something bad to happen to my dog again or something like that, and they end in that place of saying, I think it's time. I take that back. I'm sure there's some scenarios where you could talk an owner into it. But in general, I find that if you present the options and you kind of leave it for the owner to decide and they elect euthanasia, there was probably a part of them that was kind of already in that camp. They already had a gut feeling or, a decision for one reason or another that they were leaning towards. And so then it really, I think, just comes down to supporting them in whatever they decide.
Yeah, I always tell them we'll support whatever decision you make. Like I try to take the pressure off because I think that a lot of owners do feel judged sometimes for the decision. And I, don't want that to be the case. And especially if I know a pet is suffering or not going to live if we don't do one or the other. I mean, I absolutely will support them no matter what. So, and one other thing I want to just mention is in GP, your entire team should be trained to look at a pet and say, I'm worried about that pet. The gums are white. The belly looks big. When I worked GP, I had one time, a lab was dropped off for not eating, right? And it was put in a kennel. And it's like, we'll get to the drop-offs when we can. And we, an hour later got to the drop-offs and I took one look at the gums and I was like, this dog is bleeding somewhere. And so, having your team basic triage skills in a GP setting is important. And if you board, having your kennel team that's taking care of your boarders also be able to recognize those signs. So I do think that's an important point for general practitioners to just really sit with your team and let's talk about like, what would a GDV look like if it walked in the door? How could a hemoabdomen present? What are some of the things you should look at in some of these, pets and check their gums and check their heart rate when they come in, even if a doctor's not available? Anyone on the team should be able to do those things.
Absolutely. And if I can throw a shameless plug in here, we have a couple of emergency certificates on VetFolio that Army Pygott put together. Dr. Pygott, he is just an amazing criticalist and breaks it down. And it breaks so many things down in such an easy to understand way. And triage is one of those things. So it's great for veterinarians. It's great for technicians. So, maybe if you have a little bit of a greener team, there's really good resources out there to learn triage and learn the basic things that we need to be looking for.
That's why they should have the team subscription.
That's like we do. Like I said, shameless plug here, but really I've taken all of these certificates and we're in the midst of trying to put even more of that material together. And I've learned a ton from them. I've actually gone back through them multiple times. So that comes from a true, like, not just a shameless plug place, but a genuine place of like this. I learned a lot here. And it's great for every member of the team so you don't end up with those Labradors that get put in a kennel if you can avoid it.
Yeah.
I think we've all had that happen at least once.
Yeah.
Yeah. Let's talk respiratory distress. That one I think can be really scary when it comes in the door. And I know it used to be one that would really make me freeze. And now I feel a lot more comfortable after treating some of them and, really reading about what I'm looking at in depth and how to respond to it. So I would love your thoughts on respiratory distress comes in the door.
Yeah. And, it's funny because we had one recently and it was right down the road getting groomed at, a Petco. And then it went into respiratory distress. It was a Frenchie. And so they came to us. We were the closest. And fortunately, I was there and we have a fair amount of people that worked emergencies. So we kind of jumped on it. But, some of these dogs are at your practice and they go into respiratory distress while they're there, during their routine appointment, maybe after having a procedure done. So a lot of times, the brachycephalics and they get worked up, and because their palates are long and they just don't have great tracheas, everything gets swollen at the back of their throat and they just can't breathe. And they're trying so hard to breathe, they're creating more edema and it's causing also some damage to the lungs and they're just not oxygenating well. So a lot of times these dogs present, and I love the fact that my team is so well trained. And so immediately they're going to be getting stuff out to place a catheter. We're going to be giving something to calm these dogs down and providing oxygen. I think that, one of the big things, if you see a lot of brachycephalics, is a general practice needs to have the ability to give oxygen. Flow by is great. Being able to turn one of your kennels into an oxygen cage can be wonderful too, but you need oxygen capability. And so butorphanol is usually the go-to. You can give it IM if you need to. You can give it IV, ideally, if you can get a catheter in. We're going to usually do a 0.2 to 0.3 mg per kg dose of that just to calm the dog down enough that we can have them breathing a little slower and hopefully getting better oxygen. And then some of the other things that I'm going to do pretty quickly is I'm usually going to give a dose of dexamethasone to try to reduce some of that edema, usually a 0.1 to 0.2 mg per kg dose IV. I'm going to give some Cerenia to decrease some secretions. We know a lot of these dogs get so worked up, they throw up. And then you get aspiration pneumonia on top of your respiratory distress. You're like, stressing out. Ideally, you're going to have suction available because they do get so much at the back of their throats that if you can suction occasionally, that can help. Or if they do vomit or regurge, you can suction a little bit. So those are some of the initial things. Bulldogs specifically sometimes actually need a hub of ACE. I feel like they respond better and they calm down better with that. I don't do that as much with my Frenchies and my other brachycephalics, but bulldogs specifically, that seems to help. And one of the big things is, if you're giving things and this dog is just continuing to sound like, we all know the sound. I like am sweating thinking about the sound.
Right.
But if they sound like a locomotive and it's just, their color's so horrible, hopefully you're trying to get an SpO2 on them. I am pretty quickly going to make a decision to just give them propofol and intubate them and just get oxygen in them. You really just need them to calm down so the swelling goes down, and you need to keep their oxygen levels up while that's going on. And I think that scares people. Mm-hmm. It scares people to, intubate them. But I find that if I give them some propofol and I intubate, I can keep them on, oxygen only, and maybe like a 0.5 ISO, like a pretty low rate. And sometimes no ISO at all once they kind of calm down because they like their tube in and they like their oxygen.
Oh, I can breathe again.
Yeah. They're like, it's a miracle.
Or breathe for the first time.
Yeah. And then, give them a little time. Now, one of the things I talk a lot about, we want to reduce the swelling, we want to get them oxygen, we want to calm them down. But one thing I learned about recently that I've been doing more of is a temporary palatopexy. Do you know about those?
Okay, so I know about these, not enough to feel comfortable doing one, unless kind of like the GDV. I was, in a situation with no other choice. It's like a tacking suture. You pull the soft palate forward and it's like a tacking suture.
Yeah. So those dogs that you look in the throat and like literally the soft palate is sitting over the trachea opening. And then every time, you go to extubate them or they just start again and just sucking that tissue in. And so I found that I can wake them up better and faster if I tack that soft palate. And so all I do is I, use some lidocaine and I kind of pull the palate forward and see where it's going to land. And I put a little bit of lidocaine there. And then I will use like aught suture and just a taper needle. And I'll go kind of through. It's kind of the hard soft palate junction area,
That
is
makes
where
sense.
you end up usually. Yeah. And then I'm just going to pull like the corners of the soft palate forward and tack just with simple interrupted sutures and usually like one in the middle. I don't do like a lot of sutures. This is a temporary procedure. And all you're trying to do is make it where that dog doesn't have that extra tissue that they're working against to try to breathe. And I think the first one I did, I was kind of like, you're working in the back of the throat and it's swollen and but now that I've done it a couple of times, it just gets easier and easier. And if you just have basic understanding of surgery, you will be fine doing it. And again, these are situations where you have to do something.
Right.
Like you have to do something to get these dogs to be able to breathe better and get them more stable. And it also gives the owners time to set up like permanent surgery. And a lot of them see how much better the dog is breathing. And they're like, oh, like I need to get surgery done. But if you're in a general practice, I think GPs should be perfectly capable of, placing catheters, giving something to relax them, giving something to reduce the swelling, giving oxygen, and then being able to induce and intubate if they have to. And I wouldn't wait too long to do that if the dog is still really, really struggling.
I think that is all amazing advice. The sedation was one of the things that scared me for a long time. And then, talking it over with Army several times and understanding the physiology really changed my outlook on it. Of by not sedating them, you're actually creating more respiratory work and you're worsening the situation. So get that torb into them, calm them down, get that IV in, go slow and stepwise if you have to, keep the oxygen flowing. Suction doesn't have to be fancy. It can be a red rubber on the end of a syringe. You can hemostat some gauze and get back there and swab a little bit too. So a lot that we can do. And sometimes, like you're talking about, we don't have the option for referral in GP because they're not going to make it to the ER. So you have to be ready to intubate. One thing I actually just learned about that I wanted to ask you about was the rapid intubation protocol in these guys. And I'm going to completely butcher it, so I'm not going to get into detail, but something about the way that you induce them being different from how we would normally induce anesthesia in order to keep some of the tone in their, like I said, I'm going to butcher this, in their larynx until you're actually ready to place the tube.
It's called rapid induction protocol.
It's either rapid induction or rapid intubation.
Okay.
Yeah.
And is it different drugs to induce?
No, I think it has to do with the speed at which you give propofol. That you push it much faster than you would normally do for a normal induction because you're trying to maintain that laryngeal tone until you can until you're prepared to really put the tube in. So that makes me feel better that's something that you weren't like, oh yeah, that's absolutely what we do. And you're still getting tubes into them. Yeah. Me too. So I can actually explain it the next time it comes up.
This is why we do this. I love to learn from other people, and then I like to share the things that work for me. And I think that is what makes VetMed better when we kind of all collaborate in that way. So I'm definitely going to be looking that up and seeing. And one thing I was going to say is I always ask people, like, do you know where your emergency drugs are in the hospital? Because I think for these guys, you definitely need to have your epinephrine and your atropine and all your drugs available. And, I've talked to people and they're like, we don't have anything that's like a grab and go. We have a pet that's an emergency. Everything's there that we need. And so that is an easy talking point for general practice to sit and talk about these cases, to go over what to look for, who's going to do what, where to grab things from, and to just set up an emergency drug box, like something very simple, but everyone knows where it is and they know when it is needed. I think that's one of the main things that you can do. And we kind of we're talking about essentials, and I did a thing on Instagram asking people what they thought was essential. And a lot of people thought oxygen was essential if you provide emergency services. Being able to do lab work, imaging is a big one, ideally an ultrasound or x-rays, so you can really know what is going on. And then being able to give fluids, things like that. But the number one thing, do you want to guess what the number one thing was?
I'm going to say hands, like a team that can work together.
Absolutely. I mean, time is of the essence in these things. And, a lot of times a veterinarian needs to be talking to the owner too, or people need to be communicating. And so you don't want to have to sit there and say, do this, do this, do this. You really want a team that you've talked through. If this comes in the door, someone needs to get a catheter placed. Someone needs to grab the oxygen. We need to give this and really have things flowing faster, because I think you're going to help these pets better the quicker you move. And that is just training. That's talking through it. That's doing it. After you have an emergency, it's huddling and talking about what did we do well? What can we do better? And that kind of speaks to things like you said with VetFolio, where if you don't have time, there are great, modules and webinars that you can do where you can train, and you can have maybe your leadership team train better on some of these things, because you're not going to see it all the time in GP. You're not going to see it where you get as comfortable as you do in the ER. But I think if your mind is kind of prepared a little bit, then you're going to be better off. And if your team feels comfortable with these things, really the pets are going to have better outcomes overall.
And you're going to be able to handle more. I had a case recently, it was a respiratory case, where we got the oxygen going, we gave butorphanol. The cat was not thrilled about being there. It was clearly stable enough to fight us. I was able to, with the sedation, get an IV in and scan the chest, figure out where the fluid was, but not sedate enough for me to try to put a needle in this chest. So I'm looking, going, okay, we're going to have to give propofol or, a heavier sedative in order to get this fluid out of here. But I was looking around going, I don't feel like I'm in a position right at this moment where if something happened and this cat crashed, that we would be able to respond in the way that we would need to, especially because I'm very, very fortunate to be in the area where I am. We have tons of specialty clinics with amazing doctors and well-equipped clinics that can handle a lot of things. And this cat, was still stable enough to try to bite me.
Yeah.
And so, I looked around and went, I think, of course, first do no harm. And I'm looking at this going, I don't think this is the best situation here. But when you do those trainings, and this is not by any means me trying to speak negatively about the situation I was in, it just, it wasn't a case that was handled routinely in that environment. So when you do have those trainings and, like you said, the huddle where you get together and analyze things so you're more prepared the next time, and you develop that chemistry and that comfort level, you're able to handle a lot of cases that you might not otherwise be able to handle.
Yeah. And I think, some people might worry about sending something to the ER with fluid in the chest. But I will tell you that cats that are sassy, one, the fluid probably builds up slowly and they just deal with it until they can't, right? And so a lot of them are perfectly fine. And no one is going to judge you for saying, for looking at an emergency and saying, okay, this pet is stable enough to go somewhere where they can do this, they can give it the attention it needs. I think that is doing best medicine. And I think that is why we have different people available to help pets at different times. And as long as you call and you tell us it's coming and what to expect, we're good. We'll take it.
Yes. Oh my gosh, that phone call. Again, one of those things looking back in all my years doing just GP that I hope I made those phone calls every time, because it really does make a huge difference to have a heads up of what's on the way.
Yeah. I mean, we tell the room what's happening, and then people get tables set up, and we know what we're going to do when they walk in the door, because that is what we've been trained to do. And I think we get better outcomes because of it.
Absolutely. And it just goes back to that teamwork of the coordination that's so important between GP and ER to really get the best outcome for our patients.
Mm-hmm. Hopefully this is helpful.
It was helpful for me. There were so many things that we talked about. Some of it I was like, whew, good. That's a relief. I've been doing that one. Right. Yeah. And, just things to keep in mind so that we can kind of pass these cases back and forth and get the best outcome for the pet in a way that makes sense for the owner, that's possible financially and emotionally and logistically for the owners as well.
Yeah. I love that.
Yeah. Well, thank you, Tannetje. It's always wonderful talking to you. I really appreciate you joining me.
You too. It was fun, and we'll catch up with everyone another time.
Sounds great. Dr. Crocker, it was wonderful to talk to you as always. Thank you so much for joining me. I hope everybody who tuned in also enjoyed this conversation and took away some nuggets that feel helpful in your practice life. As always, if you enjoyed this conversation, please leave us a 5-star review wherever you get your podcast to help other veterinary professionals like you find this and other great content we try to put out there. If you want to hear more, you can click on the education tab on the VetFolio website or find us wherever you get your podcasts. As always, we'd love to hear from you about your thoughts on this episode or ideas for topics you'd like to hear from us in the future. So feel free to reach out to me at dvm@vetfolio.com, or we can connect on Facebook or Instagram at Dr. Cassi DVM. And remember, if one animal is better off because of you today, it's a great day.